with me today. Um, so to kind of to start off, I guess I would want to reinforce that kind of in my world, right, in the world of economics, the culture is that the speaker says things, and then as everybody has thoughts and questions, just jump in and participate. And I don't think the room is that big today. So if we can have more of a conversation about this than a one-directional interaction, that would be dynamite. So thank you, Dr. Lichtman, for the kind introduction, and we can talk about a couple of those papers at least today. So, as I think everybody, who's paying attention knows that opioids have had economic impacts on our society and personal impacts too, right? But being an economist, we tend to have that economic impact lens of the world through, a number of channels, right? We know there's been a continuing increase in overdoses with opioid and opioid synthetic derivatives. We know we wrote a paper that we'll talk about here in a second briefly about the relationship between prescription opioids and labor force participation. At the summit we had here on campus a couple of years ago, it was powerful to hear stories from the law enforcement community who talked about how they knew they couldn't arrest their way, in their words, out of the opioid epidemic and the way that this crisis had struck their families. Before COVID put the brakes on everything, there was strong relationships between opioids and healthcare utilization, and not just for acute utilization for overdoses, but also just your opioid users were consuming an order of magnitude higher healthcare resources than non-opioid users in the population. Some of that due to differences in health state that led people towards seeking the treatment for chronic pain. Some of that, of course, is just due to the complications that come from prolonged substance use disorder. We know that opioids have had impact on the educational system and on people's human capital formation and their schooling choices early in life, and also in children and families. So kind of the way that we got roped into this, we'll come back to that in a second, was we started hearing from groups in the state, from chambers of commerce and the like, that they were looking for people for jobs, and that people weren't showing up to apply for those jobs, and they wondered if opioids had something to do with it. And so we got kind of involved in this agenda through that lens, and we started with labor force participation because it seemed like a relatively straightforward thing to measure. And to kind of give you an idea of like why economists are into some of these nuances, right? Usually when you tell somebody you're an economist, the first thing they do is slowly turn and walk away. If they don't do that, then the second thing that happens is well, how's the economy, right? Or how's the stock market? And my answer to that is I don't know. That I'm sure it's doing what it's doing, but anything that I know, that information is already captured in the market. So the market knows more than me, and I'm just a guy. Really, what a lot of economic research is about why do people make the choices that they make? And if we take some view of the world that people are making the decisions that they do to make themselves as well off as they can in some sense, why do people make the choices that they make, and kind of how does the world around them, how do the constraints that they face, affect what they perceive to be as the best way forward for them, under those limitations that they have. If we're, in this virtual world, I think everybody's used to this by now, but if I'm invaded by dogs momentarily, I apologize. But increasingly, right, and once you get away from that sort of philosophical, thought of why do people make the choices that they make, a lot of modern empirical economics research really looks at at whatever outcomes are resulting from the choices that individuals make, how as the world changes, as there's policy changes, how do we observe outcomes change, and what can we infer therefore about people's decision making as policy often affects the constraints under which individuals operate. And so if you've taken any economics, right, if you've taken Econ 101 or even intermediate, and you're sort of accustomed to thinking about, well, utility maximization subject to a constraint, a lot of published academic research, and particularly in microeconomics, looks very different from that, but all of it's still very much informed and rooted in those key seminal models. So like I said, about 4 or 5 years ago, we wrote a paper on prescription opioids and labor market outcomes. And the punchline that we brought back to the state of Tennessee was that a 10% decrease in prescription opioid use would lead to an additional $825 million in personal income across the state. And when you think about what $825 million in personal income would mean to the population, right, but also to the tax base, and to the public good that we could provide with that additional income, that's a powerful thing. And decreasing prescription opioid use is a good goal, especially in a world where we know that have been oversaturated with prescription opioids for quite some time. But our message when we took this kind of in popular press was, don't shut it off. Be extremely careful if you're going to go shutting off the taps. So I'm not sure, because everybody's got their screens off. I can't see who's in the room. But in case this was, before you were born, there was a fantastic movie in 1984 called 84, called Ghostbusters. And Ghostbusters was as much of a story about entrepreneurship as it was about the supernatural. And there's a climactic scene in the movie where these guys have a containment unit full of supernatural things, and the EPA is William Atherton there, and he's yelling at the guys to shut off the unit, and they're saying, look, this thing behind us may be scary, right, but if you shut it off, it's going to get a whole lot worse. And they're ignoring the warnings are ignored, and they do shut off the unit, and things kind of go badly from there. And that was our message about this first paper, is that yes, the prescription opioid epidemic is bad, but if you go shut it down with ham-fisted policy, things are going to get a whole lot worse. And the reason is that part of what we have to consider when you view social problems through the world of people who think about choices all day, not just one aspect of it, but about trade-offs between choices, is dealing with social problems one at a time is a bit kind of like whack-a-mole. That is, as soon as you swing that mallet, right, and you take down one aspect of a social problem, then another one crops up and another one develops. You see that all the time, in things like trying to develop public health systems in developing countries. That as soon as you take care of some of the causes of mortality that are relatively cost effective, then you run into funding issues immediately, because people start to suffer from more expensive ailments as things like sanitation and clean water happen. And the same thing's true with dealing with social problems, in OECD countries too, is that as soon as you tend to generate, if you treat one sort of symptom of what's going on, then the first thing that's going to happen is the effect's going to get displaced. Is there's still pressure underneath? There's still, in this case, that there's still something driving, the need for people to use substances. And if you go after a particular substance, then we're not saying that's not worth doing, but what it's ultimately going to end up doing is create substitution, as you're going to have people that are substituting from some substances into another. And so kind of in the spirit of that, we're talking with a former University of Tennessee faculty member who's now at Claremont McKenna, and she said, well, have you looked at what opioids is doing, in the world of child abuse and maltreatment? And we said, no, we haven't gotten to there yet at all. When you look at what we're just starting to understand, what the true cost of adverse childhood experiences, ACEs, are, right? One of our faculty in one of the deans of the College of Nursing, Nan Gaylord, has done some amazing work, in that area. The cost of adverse childhood experiences and child abuse is massive. And some economic impacts estimates place that at almost $1 million over the course of the life cycle, through various ways. And so when we started looking at how do opioids affect child maltreatment, what we saw was really strange. And that was that over the last few years, the results that just from a typical regression model and just correlational evidence suggested that more opioids meant less child abuse. And in a world where we are really sure that whatever marginal benefits opioid prescribing was bringing to our society, those had been used up a long time ago, right? We're not exactly sure where optimal is, but we know that we're well past that optimal and into the more than we should be range. Why do we see that relationship? And so one of the things that's we knew was going on in the background was, opioids continues to be, a big part of the ongoing conversation in terms of, these massive challenges that we're facing, not just as a state, but as a country, but, it's particularly pronounced here. When we look at what's going on with prescription opioids, though, it's going in the other direction. Opioids have been peaked at around 2010, right, or 2012, somewhere in there, depending on which data set that you're using. And prescription opioid prescribing has been falling for over a decade. Meanwhile, the overdose rate, it keeps going up and up and up. And when we take that same kind of pattern. We say, okay, the prescription opioids or opioid prescribing is falling, but tragedy related to opioids is increasing. What does that look like when we go to lay it over child maltreatment? And when you take a look at in that context, you see a very similar pattern. So I do wish this graph was scaled a little bit better. But what you can see is, I'm not sure if you guys can see my cursor, but that the blue line here is allegations of child maltreatment over a census of state child protective service agencies. And we see that the allegations of child maltreatment are gradually increasing, but there's really a kink here in about 2011. And then they begin to increase after that a bit more sharply. You see that substantiated cases of child maltreatment, although smaller magnitude, are decreasing and considerably until 2011. There was a kink in 2011, and after that, substantiated cases of child maltreatment, began to continue to increase. And so we said, okay, what's going on with that, right? So maybe the story then is not so much that more opioids means less child abuse, but that is there a relationship between decreasing opioid prescribing and increased child abuse. And so the challenge behind this, of course, all boils down to what was going on in the 20 years before 2010 and what happened in 2010. And so, which was specifically the reformulation of OxyContin. And so, we know that from about 1990 to about, to 2010, that there was this massive increase in the way that opioids were prescribed, and particularly the one that some really good research recently has absolutely nailed as the culprit. It was OxyContin. OxyContin is just different. But a lot of the push to increase the quantities of opioids to treat pain came from the supply side, not from the demand side. So there's some group out there, two very prominent economists, Ann Case and Angus Deaton, and they have this deaths of despair story that's the opioid epidemic was created by people, or not created, but was in no small part fueled by people who were not happy with the way things, with their economic prospects and the trajectory of their life. But we also know too that really the push from this did come from the supply side, from some of the pharmaceutical companies. And a lot of the justification that went into increasing opioid prescribing to treat chronic pain was ultimately justified by a one-paragraph letter to the editors of the New England Journal of Medicine that challenged not using opioids for chronic pain, with an unsupported statistic that they said out of a study of 11,000 people, only 4 showed signs of dependence from opioids. And while that's from an evidence perspective, that's so thin, it doesn't exist. But it's since been cited 600 times in subsequent studies to justify opioids in the treatment for chronic pain. And the practices in pain treatment were changed based upon really weak and non-existing evidence. But in 1995, things hit an inflection point when OxyContin gets approved. And OxyContin scripts alone increased from 670,000 per 6.2 million per year in the first 7 years over that it's after it was approved. And a lot of that was driven by a really aggressive marketing campaign to try to convince primary care providers that it was safe to prescribe, a straight opioid, for the treatment of pain, and with evidence that we know is fraudulent, that it wasn't habit forming. Further, the Joint Commission on Hospital Accreditation recommended treating pain as a 5th vital sign in standards of care. And in fact, if you go now, Steve, to the even in Children's Hospital, right? You have your remote where you can complain if you can signal if you have problems. Pain is the biggest button on there. In 2009, those standards were deleted, but practices continue, right? Once people develop professional practices, that has inertia. And one of the things in 2001 that happened was Congress began to track patient satisfaction and experience in pursuit of the quality and consistency of care. And the patient experience and the quality thereof was linked to hospital reimbursement rates in future years. And 3 of the 25 questions on that survey that were used as part of the formulary for hospital accreditation in future years revolved around pain management and were you satisfied with the way that your pain was managed. In 2010, the ACA linked the scores on that patient satisfaction survey to reimbursement rates. And we also know that providers exhibit heterogeneity in the adaptation of new practices and respond at different rates to incentives. And there was a massive kickback plan on the part of these manufacturers in order to increase incentives. And aside from treating chronic pain, opioids are not that effective in treating acute pain. And so a lot of the evidence that was given for primary care providers to be prescribing opioids for acute pain, again, was really dubious at best. But what it was successful at doing is creating a population of dependents. And so through the kickback schemes and through variation in prescriber practices, estimates placed the dependent share of the population that was dependent on opioids at between 5 to 10% by about 2009. The other feature about OxyContin that in particular was really is different. It's in retrospect, it's quite horrible. Is that most opioids, almost all other opioids that you get, are paired or mixed with a compound that serves as kind of a governor switch. So if you get prescribed Percocet, right, that's got oxycodone in it, it's also got acetaminophen. And if you take too much acetaminophen, you're going to have organ failure. You're going to feel awful a long time before that. If you, one of the reasons that, opioids are helpful is they can, serve as a anti-laxative, right? I forget the term of it, but it'll decrease motility. And diphenoxylate is a compound where they mix that with nightshade. So to make sure that you're not taking more of that than you should. So if a substance is sufficiently addictive to where you're willing to cut it with nightshade to keep you from from taking too much of it, you should take that seriously. But OxyContin was just straight oxycodone. There was nothing in there that was mixed with that. And it was chemically built to deliver an unusually high dosage for a protracted period of time. And in the marketing literature now, you read this and you feel sick. OxyContin is marketed as the opioid to start with and stay with. So because of that governor switch, or that lack thereof, OxyContin made for a particularly good candidate for abuse. And one of the ways that was because the time release component of OxyContin came from the physical structure of the pill, that you would ingest the pill, and over time, your body would break it down, and you would take an additional doses of oxycodone would get released. But it was well known among people who had developed substance use disorders that if you just crushed the pill, right, and ingested it all at once, then you got a very quick release of everything that was pent up kind of in there. And in 2010, they reformulated the pill to make it less abuse friendly. So when you tried to smash it, it just turned into paste. And that meant that if you were accustomed to the level of euphoria that you would get from a couple of crushed OxyContin pills and getting all of that at once, that you simply weren't able to get that. And so for people who were, the thought was that if people were taking these pills in the way that they were intended, then they wouldn't be affected. But the people who were taking these pills, who had substance use disorder and were taking these pills, for the euphoria, wouldn't be able to do that anymore. But they didn't really consider what was going to happen when you had a group of people who were dependent upon a substance, and then that substance is taken away from them. Because when you have addiction and dependence, then just because the access to that substance is compromised or gets more irregular or hard to get, that doesn't mean that the problem of the individual, of course, is solved. And so what's the relationship, right? So we see this increase in child abuse and child maltreatment after 2010. And our question was what does the reformulation of OxyContin have to do with that? Because after 2010, you see that opioids decrease and child maltreatment increases. So what kind of drives that? Well, if you have a group of the population who's dependent and there's a reformulation of OxyContin, opioids become less available and they're less misused. But we also know that that's going to generate substitution to more severe substances, like initially heroin, later fentanyl, and fentanyl is we're still trying to unpack the damage that's wreaking in many aspects of our society. But one of the things going to come from the substitution to worse substances, to uncontrolled substances, is probably an increased child maltreatment. So this is a bit of a complicated chain. So we'll kind of run through it. There's clear evidence from the economics literature and from other literatures and from the clinical literature that both the two interventions, the reformulation of OxyContin and the implementation of must-access PDMPs, prescription drug monitoring programs at the state level, reduce the availability of prescription opioids. Those were two programs. The reformulation was undertaken solely by Purdue Pharma, but states also began to realize that they had a number of providers who were looser perhaps with their DEA pads than they would prefer. And so they began to not only just track, those prescriptions, but also to require providers to consult the database before they write the script. And that's what the must access provision there is about. We also know that there's plenty of evidence that as opioids became less available, as those restrictions went in place, people substituted towards heroin. You can see it in overdose deaths. You can see it in increased incidences of bloodborne diseases stemming from needle sharing. And you can also, Justine Mallett at the Bureau of Economic Associates has a couple of really interesting papers looking at just when you shut down pill mills, that heroin markets tend to crop up adjacent to that. And the final link is the link between substitution towards more severe substances and child maltreatment. Most of the public health literature that I've read and most of the clinical literature that I've read says if you have a substance abuse problem, seek treatment, and I agree with that. But even though it's kind of common knowledge, it's not said out loud that often that not all substances are equally dangerous, and we've known this for a long time. That and a survey of social workers and CPS agents, right, 7.5% of them said that alcohol alone was a factor in abuse and neglect. But once you get drugs and alcohol involved, particularly uncontrolled substances, that's a recipe for child abuse. And even within very similar pharmacological classes of substances, you see variation in what that substance means in terms of someone's ability to care for their child or to completely lose the capacity to care for a child. So for example, there was fundamentally differences in what was going on with child maltreatment when cocaine was spiking versus when crack, that derivative, was striking from there too. It's in the temptation in a lot of these cases to think about, well, is it because of parents' behavior while they're intoxicated that leads to them, not mistreating their children? But the answer is not necessarily, right? That a lot of it has to do with withdrawal. And if any of you have family members with addiction issues, I'm sorry. My heart goes out to you because I've seen it, and the withdrawal from opioids is bad. The withdrawal from heroin is horrifying. And it's immediate. I have 3 kids. I love them dearly. I can't imagine trying to parent going through, what the symptoms of heroin withdrawal look like. And so, for the people who had substituted, right, from these substances that were designed to be addictive, to be sure, but also to keep them as high functioning human beings for a long period of time, they end up substituting into these types of substances where there's no concern for that, right? And the dose is a lot more irregular, and somebody could go spend their whole allotment on heroin and get a great bag of heroin, or they could go spend their whole allotment on that and get a really weak bag of heroin that wouldn't satiate. And so then there's lots of room for additional choices that lead to maltreatment there. So it's a long chain, but it's a chain reaction that leads from, you have a pent-up population of dependents who are on substances that are addictive but designed to keep them high functioning. Access to those substances is cut off. They end up substituting towards things that are worse, and that leads to child maltreatment. So from a experimental variation perspective, right? This being the science forum, ideally we would have something approximating a randomized controlled trial, right, in the figure above, and we don't have that. What we do have is we know that OxyContin was not distributed uniformly across the United States. And we can look at measures of where OxyContin usage is most pronounced prior to the reformulation, because those are the places that should be more affected by the reformulation in terms of their population substituting into other things. And so that's the approach that we're going to take. We're going to have just sort of an event study approach where we know that certain places are more vulnerable, if you will, to the adverse consequences of reformulating this substance. And we're going to see what happens. So when we take a look at how did the reformulation work, the answer is yeah. If the effect of the reformulation was to reduce OxyContin, it was effective in doing that, and that it did change the extent to which oxy was used, and reported misuse in the NSDUH And the places, and it was the places where it was most misused before that the largest share in misuse reduction happened. So kind of from that first order perspective, Oxy did lead to the reformulation did lead to decreased misuse of OxyContin. But what we also see is when we take a look at what happens from an event study perspective in the high exposure counties, and so these coefficients are interactions of your Z-score of your pre-exposure level of 2009, right? How oxy-saturated was your county, and the reformulation happens. We see that that allegations of physical abuse and neglect increase consistently and diverge from the low exposure counties after that reformulation. We also see that and so one of the natural concerns is, well, is this generating allegations, but is there anything to it? Yes, there is something to it. We also see that in those high exposure counties before the reformulation, there's increases in physical abuse and neglect that are substantiated cases. And that's substantiation is a pretty high bar and burden of proof. One of the things that we are concerned about too is who does the reporting, right? And because you can think about that, if the reformulation made somebody's problem more visible, if there wasn't true abuse happening, is there a way that having kind of a more visible substance abuse habit would just lead to greater concern and greater inquiry? But the answer is no. We weren't getting there weren't random calls about people allegedly mistreating their kids. Most of these came from professionals. Most of these came from teachers. Most of these came from educators. Most of them came from the mandatory reporters of the world who saw evidence that they couldn't look away from. And in fact, somewhat reassuringly, tragically, for the validity of the result, when we take a look at the reporting by non-professionals like family members, neighbors, et cetera, it's mostly noise. That wasn't where the reformulation in those high exposure counties generated that behavioral change. So with that tragic result, the next thing that we sort of considered is, okay, well, and we can't wind back the clock and do anything about it, right? Sometimes there are things that you can't do anything about, but it really matters if you could do something with it. And in this case, what we have to consider is, what are the other policies that states can put into place to help mitigate these adverse consequences, from the spirit of not all substances that are intoxicants are created equally in terms of the way that it affects your ability to relate with your kids. And so one of the things that we thought was interesting was, and again, this is as early on in the medical marijuana journey, but the states with medical marijuana access didn't see the same adverse effects of the reformulation of OxyContin on kids, right? You see that all that variation and the allegations of physical abuse and neglect, that gray series there, that's the states without medical marijuana. The states with the medical marijuana, you don't see that effect. And so our takeaway from that is we know from other literature that marijuana can be used as a crutch for prescription opioids. That if you have somebody with an opioid issue, that marijuana is also effective in treating pain, but it's also for people who are self-medicating for other reasons. That marijuana is a good diverter from keeping people from the really vicious uncontrolled substances. We also could talk about which policies help and which don't. So some states have targeted treatment programs, specifically that if you are if you're pregnant and you have substance use disorder, that you can get into treatment with medication assisted therapy, with buprenorphine preferably, but methadone if it's what's needed or what's available, in order to get people away from uncontrolled substances. We see that the variation in child abuse is far more pronounced in those states without the targeted treatment plans than with the states with. And we can cut this lens a similar way, and although the results aren't statistically significant, they're still indicative that not just having treatment plans available, but prioritizing admissions into inpatient treatment and into medication-assisted therapy regimens for women with substance abuse disorder who are pregnant is a great way to reduce the adverse consequences on children. And that's true both from the allegation standpoint, and it's a bit more precise when we look at the substantiated cases as well. One of the things that we also wanted to consider, though, was what were the effects of prescription drug monitoring programs. So there's reasons to suspect that these effects would act a bit like the reformulation of OxyContin, but also reasons to suspect that it would be a bit different. And part of the reason is that kind of the dominoes were already had fallen from the reformulation for a couple of years by the time that PDMPs go into effect. And so your most severe dependents were probably already pushed over the threshold in the aftermath of the reformulation. So this would act kind of on a different part of the continuum of opioid dependency, but it was also because it was an additional means of restricting access to prescription opioids. Our fear was that these policies too would also generate substitution patterns towards uncontrolled substances and have spillover effects for children. And so we see that the pattern's kind of weird, right? That in our data set, there was a mass of states that implemented around 2012, although a lot of states, implemented at different times. So that's why we kind of zero in on that as okay, that's when the real massive adoptions happen. And we see that for the states that never implemented, there was a decrease in child maltreatment, but there's nice parallel trends beforehand. When we take a look at substantiated cases, right, you see that there's a hiccup there where substantiations are declining, and then after the reformulation and after the implementation of PDMPs, that the substantiations began to increase again. And when we take it just to kind of a simple differences and differences framework, we see that in the full sample, right, across implementation in PDMPs is linked to both an increase in allegations and substantiations of child maltreatment, and that the effects in counties that are above the median tend to be at least a bit larger, even if they're not statistically significantly differently larger than counties that are below the median. And so we don't have the same, and this particular regression framework is not as continuous measure friendly as the other one is, but we can still look a bit for that heterogeneity. And we see that, yeah, the counties with the 2009 higher exposure levels are again more likely to see larger increases in child abuse and neglect in the aftermath of restricting opioids. So kind of what do we learn from all this? Kind of obviously on the surface, right, the PDMPs and reformulation, right, I believe that states were coming from a good place with PDMPs. It's hard to say they make the same claim that anything about Purdue Pharma is coming from a good place. That can have unintended consequences. And so, we learn from those differential effects. We do see evidence consistent with adverse substitution patterns that economists are into on this very high stakes issue, right? That the child maltreatment is incredibly important. The overall economic impact estimates of child maltreatment range from, something I've seen it as high as $2 trillion per year. And I think that's probably a bit of a stretch, but we know that the emotional costs, the economic costs that, the wounds that kids get don't heal. They cover and they get infected and they get worse, right? But they don't really heal unless somebody can get some serious therapy. And so those adverse childhood experiences, we know they have lifelong consequences from that, and the continuing undertow from that is heartbreaking. So overall, what do we learn? That when you're dealing with issues like addiction, you have to take substitution seriously. That's kind of a tempting thing to say, like, well, that's the bad substance, and we want to get rid of that substance. But if we don't think about the things that are going on at the personal level that drive and across people, right, within our state and within our country, that drive people to use substances. If all you do is go after the substance, but you don't try to help the whole person, the main thing you're going to get is substitution, because that pain is still going to be there, and people are going to find something to try to treat with it. And so we have to consider how those underlying issues are going to lead to displacement and substitution if you don't treat them. And so for us, one of the big takeaways from this was we know that not all substances are created equal in terms of the harmful effects that they have, not just on the user, but on people around them. And so, for us, the key takeaway from this was, what do we need to do to make buprenorphine and Suboxone more accessible? And you have some critics of medication-assisted therapy who they're smaller in number and less credible by the day, but they still say things like, well, you're just substituting drugs for other drugs. And our response to that is, yes, exactly. steadier, more reliable dosage controlled drugs with far less vicious withdrawal effects. And so, we know that if kids are around, that their world is far better if their parent is on a well managed regimen for medication assisted therapy than if their parent is in a constant state of higher withdrawal and seeking uncontrolled substances and hazardous conditions. So that's kind of what I wanted to talk to you guys about. So any questions, comments, thoughts you have? I'd love to spend, the 20 minutes that we have, I think, left just hearing what you guys have to say and then spending time with you.
And may I invite all of you, please, to turn on your videos and to turn on your mics, and you can ask Dr. Harris questions, make comments directly. And we also have questions available if you'd prefer to use chat.